All right, we will come to the prostate cancer part 12, surveillance versus external beam radiation randomized trial. Wide-mark study compared watchful waiting to external beam radiation at dose of 64 to 68 gray in 214 men with clinical stage T1B to T2 and N0M0 prostate cancer. With minimum follow-up of 16 years, there was no difference in disease-specific or overall survival. However, external beam radiation therapy reduced biochemical, local, and metastatic progression. Caveat study, the radiation dose used in the external beam radiation group 64 to 68 gray is suboptimal by current standard. Recurrence is more common within external beam radiation dose less than or equal 70 gray. PROTECT trial, prostate testing cancer and treatment, mean age of 50 to 69 years, with clinically localized prostate cancer and PSA 3 to 20, where the randomized to external beam radiation 74 gray radical prostatectomy or active surveillance. So at median follow-up of 10 years, there was no difference in deaths from prostate cancer or deaths from any cause between the radiation and radical prostatectomy and surveillance. If the data are analyzed based on the treatment received rather than by intention to treat, the treatment with either radiation or radical prostatectomy result in significant lower risk of death from prostate cancer. Active surveillance resulted in significantly higher rate of clinical progression and distant metastases compared to men who had radiation or radical prostatectomy. Surveillance resulted in a lower risk of erectile dysfunction than external beam radiation or radical prostatectomy, a lower rate of urinary incontinence than radical prostatectomy, and lower risk of bowel dysfunction than radiation. Caveat: the radiation dose used in this study was similar to current regimens. Also, we show you that the caveat were discussed previously in the previous slides. So here, radical prostatectomy versus radiation randomized control trial, PROTECT trial, prostate testing for cancer and treatment men with age of 50 to 69 with clinically localized prostate cancer and PSA 3 to 20 were randomized to radiation 74 gray, radical prostatectomy or active surveillance. This study and assessed patient with age of 50 to 69, and those have clinically localized prostate cancer and PSA 3 to 20. With a median follow-up 10 years, where was no difference between the radiation and radical prostatectomy in terms of clinical progression, metastasis, need for androgen deprivation, death from prostate cancer, and death from any cause. Radical prostatectomy associated with higher rate of erectile dysfunction and urinary incontinence than external beam radiation, where radiation is associated with higher rate of risk of bowel dysfunction than radical prostatectomy. Caveat: the radiation dose used in this study was similar to the current regimens. Also, Paulson study randomized 97 men with clinical stage T1, T2, and 0M0 prostate cancer to radical prostatectomy or radiation. Subjective were occurred in the late 1970s. 5 years failure-free survival was better for radical prostatectomy than radiation. Caveat: this data is not applicable to current practice because contemporary diagnosis and staging are different than those studies. This study was conducted before PSA was available. The radiation dose used in this external radiation group is less than 70 gray, is suboptimal by current standard. Recurrence is more common with radiation dose less than or equal 70 gray. And also this study population was rather small. A COCORA study made with clinical stage T2B, T3, L0M0 prostate cancer were randomized to radical prostatectomy or radiation that 60 to 70 grade. Androgen deprivations, oral estrogen or chydectomy plus anti-androgen or luteinizing hormone agonist or plus anti-androgen was started 2 months before radical prostatectomy and radiation and continue until biochemical or clinical progression. After 10 years of follow-up, the overall survival and disease-specific survival were slightly higher for radical prostatectomy, but this difference were not statistically significant. Caveat: this study is not applicable to current practice because the treatment in this study androgen deprivation continue indefinitely after curative therapy, and radiation dose less than 70 is considerably different than contemporary treatment. We have Lineran study 89 men with PSA less than or equal 50 and clinical stage T1B, T3A, N0M0 prostate cancer were randomized to radical prostatectomy or external beam radiation plus brachytherapy. This study was closed early because of poor accuracy. With few participants, the study was underpowered and difference in survival could not be determined. SBCG 15, this study is randomized men with locally advanced prostate cancer to radiation androgen deprivation therapy or to the radical prostatectomy plus adjuvant radiation. Results are pending of this study. Then we have external beam radiation anti-androgen deprivation therapy versus anti-androgen deprivation therapy alone, randomized for locally advanced N0M0 disease. Radiation with anti-androgen achieve better over all disease-specific survival than androgen deprivation therapy alone. SBCG7 study 875 men with clinical stage T1, T3, N0M0 prostate cancer and PSA less than 70 who were randomized to lifelong flutamide with external beam radiation 70 gray or lifelong flutamide without radiation. Men receiving radiation and flutamide has significantly lower 15-year risk of death from prostate cancer. Caveat: few oncologists utilize lifelong anti-androgen monotherapy as a standard treatment option for advanced prostate cancer. Whereat et al. 2011 study 1,205 men with locally advanced N0M0 prostate cancer, clinical stage T3 to T4, or T2 with PSA more than 40, or T2 with PSA more than 20, and Gleason score of 8. Men were randomized to lifelong castration with radiation 65 to 69 gray, or to lifelong castration without radiation. After 7 years, adding extended beam radiation to castration improved overall survival and disease-specific survival. In short-term, quality of life was worsened in the radiation group, presumably from radiation related to acute side effect, but in the long term, there was no significant difference in quality of life between groups. External beam radiation versus chemotherapy, randomized trial. Both of the studies below did not meet the accurate goals, so the definite conclusion cannot be drawn. However, cryotherapy appeared to be less effective than radiation for local advanced stage T2C or T3B prostate cancer. Calgary trial closed prematurely due to slow accuracy. So 244 men with stage T1, T3, N0M0 prostate cancer and PSA less than or equal 20 were enrolled. Men with Gleason score 8 were enrolled only if pelvic lymph node dissection was BN0. Participants were treated with 3 to 6 months of new adjuvant androgen deprivative therapy with an luteinizing hormone releasing hormone agonist and randomized to chemotherapy or radiation 68 to 73 gray to the prostate and similar vesicles lymph nodes were not radiated. Radiation and chemotherapy and had similar overall disease-specific survival at 5 years. Chemotherapy resulted in significantly worse sexual function, where other quality of life domains were similar between groups. On trial, this study did not meet the accurate goals. 64 men with clinical stage T2C, T3B, and 0M0 prostate cancer were randomized to radiation 66 gray or chemotherapy. Men with PSA more than 25 were enrolled only if pelvic lymph node dissection or biopsy was BS0. Androgen deprivation with luteinizing hormone agonist, releasing hormone agonist, started 3 months before radiation or chemotherapy and was continued for 6 months. At 8 years follow-up, disease-specific and overall survival were similar, but PSA recurrence was significantly more likely with chemotherapy, 59% versus 17%. Radiation alone versus radiation with brachytherapy, randomized study indicate that the radiation plus brachytherapy may decrease local recurrence and biochemical failure compared to radiation, but there appear to be no difference in overall survival or prostate cancer specific survival. Hoskins 2012 that study 220 men with PSA less than 50 and clinical stage T1 to T3. In 0M0 prostate cancer were randomized to radiation alone 55 gray or radiation plus HDR. 76% of the patients receive androgen deprivations 6 months for intermediate risk and less than or equals 3 years for high risk patients. After mean follow-up of 7 years, radiation and plus HDR reduce biochemical recurrence compared to the radiation alone. Overall survival and side effects were similar between groups. Caveats: the radiation does used in the radiation extended beam radiation alone group is optimal by current standard. Recurrence is more common with radiation dose less than 70 gray. Dice et al. 2017 men with non-metastatic clinical stage T2 to T3 and pathological stage N0 prostate cancer were randomized to extended beam radiation 66 gray or radiation with temporary brachytherapy, radiation plus HDR. Neither group received androgen deprivations. After median follow-up of 14 years, radiation and HDR significantly lower biochemical recurrence compared to the radiation alone in both intermediate risk and higher risk cancers. Local recurrence was lower, also lower after radiation and HDR based on the prostate biopsy 24 months after treatment. There was no difference in overall survival, prostate cancer specific survival, or side effect between the groups. Caveat: radiation dose used in the radiation alone group is suboptimal by current standard. Recurrence is more common with radiation dose less than or equal 70 gray. Morris et al. 2017 398 men with intermediate or high risk localized prostate cancer were treated with 12 months of androgen deprivation therapy and 46 gray of pelvic radiation, and then randomized to either radiation, extended beam radiation boost total of 78 gray or brachytherapy post. Essentially, this study compared radiation plus anti-androgen deprivation therapy to the radiation plus brachytherapy plus anti-androgen deprivation therapy. At median follow-up of 6.5 years, men who underwent radiation and anti-androgen had lower rate of biochemical failure compared to men who underwent radiation plus brachytherapy plus anti-androgen therapy. However, there was no difference in overall survival. Urinary side effects were significantly more common in men treated with radiation, brachytherapy, and anti-androgen deprivation therapy. This study used radiation dose and brachytherapy dose that is similar to current practice. Radical prostatectomy versus brachytherapy randomized trial, that's Gabretti study 1. Upper pubic radical prostatectomy versus brachytherapy, men with very low risk or low risk prostate cancer were randomized to bilateral nerve sparing open retropubic radical prostatectomy with bilateral pelvic lymph node dissection or to 125 brachytherapy, at least 140 gray. At 5 years follow-up, there was no difference in biochemical disease-specific survival, approximately 91% with 1 year of treatment. Men undergo retropubic prostatectomy, radical prostatectomy were more likely to have sexual dysfunction, while men undergoing brachytherapy were more likely to have irritative voiding symptom. However, 5 years survival of 5 years follow-up, there was no difference in bowel, urinary, or sexual function. Caveat also, this patient population and the treatment study are typical of contemporary practice. The follow-up is only 5 years. Also, surveillance is now recommended for most men with a very low risk or low risk prostate cancer. Gepard study 2, robotic radical prostatectomy versus brachytherapy. Men with very low risk or low risk prostate cancer were randomized to bilateral nerve sparing robotic radical prostatectomy or to 125 brachytherapy, dose not specified. At 2 years follow-up, there was no difference in biochemical disease-specific survival, approximately 97%. Men undergoing robotic radical prostatectomy were more likely to have urinary incontinence with 6 months of treatment, while men undergoing brachytherapy were more likely to have irritative voiding symptom during the entire 2 years follow-up. Caveat also, this patient population and treatment studies are typical of contemporary practice. The follow-up is only 2 years. Also, surveillance is now recommended for most men with very low risk or low risk prostate cancer. Spirit trial open retropubic radical prostatectomy versus brachytherapy cancer because of poor accurate but some quality of life data was published for the men enrolled. At median follow-up of 5.2 years, men treated with brachytherapy reported better urinary and sexual function. Okay, this is the end of part 12. We'll meet again in part 13.